Welcome to our Mary Greeley Primetime Alive presentation, Cancer Prevention Screenings. I am Wendy D'Amato, and I assist Vicki Newell with the Primetime Alive program. As a reminder, if you'd like more information about Primetime Alive and how to join, please visit our website at mgmc.org/PTA. Our presenter today is Dr. Sonam Patel, and Dr. Patel received her medical degree from Rutgers Robert Wood Johnson Medical School and her Bachelor of Science from the University of Michigan. She completed an internal medicine residency and hematology-oncology fellowship at Loyola University Medical Center. Dr. Patel joined McFarland Clinic Oncology and Hematology Department in August of last year. Please welcome Dr. Patel.
Thank you so much. So today I chose to talk a little bit about cancer screening, and this is a topic that's near and dear to my heart as an oncologist. I just want to make sure that everyone is sort of aware of what they should be screened for and be able to talk to their physician about it and advocate for themselves as well as their family members when it comes to cancer screening. So just to start off with, I wanted to lay the groundwork with some cancer statistics. And so to your left over here, you can see new cancer cases in 2021. And so the most common types of cancer in America included breast cancer at 15% of the new cases, prostate cancer at 13% of the new cases, 12% was lung cancer, and then 8% represented colon and rectal. And together, these are about half of the new cancer cases in America. The other half is representative of other malignancies that we're not going to talk about. And on the right, you can see cancer deaths in 2021, and disproportionately, lung cancer represents about 1/5 of cancer-related deaths. Colon and rectal cancer represents about 9%. Pancreatic cancer represents about 8%, and breast cancer represents about 7%. So if you notice a kind of common theme, breast, prostate, lung, and colorectal cancer are really the most common cancers, as well as some of the most commonly causing death related to cancer. And this is important because all of these tests have screening studies that you can do to help catch it early or even catch conditions that may suggest that you have a higher risk of progressing to cancer. On the right, just sort of another schemata from the SEER Cancer Network that shows 2019 out-of-pocket cancer costs were highest for, again, the same cancers, breast cancer, prostate cancer, colorectal, and lung cancer. And it's mostly related to the high prevalence of these cancers that we just spoke about. So before we get into talking about each other specific type of cancer, I wanted to talk a little bit about just the basics of screening tests and what makes a good screening test, why we do this, and kind of the ABCs of that. So first thing, what is the purpose of a screening test? And really, a screening test is meant to be an easy test that patients can go through to find cancer at an early and curable stage. Now, there are some other things that screening tests can do, including like I mentioned, finding pre-malignant conditions, and some screening tests can actually be therapeutic, meaning can biopsy or remove areas that could become cancer in the future. Who should get screened? And it depends on a lot of different factors that we're going to talk about throughout this presentation, but that includes age, gender, family history, and personal history as well. And this one's important. So how are screening guidelines determined? So all of the guidelines that we're going to talk of are based on randomized controlled trials. So that means they took an arm of patients that went through the screening test and an arm of patients that did not, and they compared the two groups. And there was always a clear benefit shown in terms of screening for the ones that we're going to talk about. And benefit includes mortality benefit, so patients who got the screening test lived longer, and then it also shows a benefit in terms of symptoms related to the cancer. And then what's important with this is that controlled trials and studies are always ongoing, and so guidelines can change over time. And I'll point out a couple instances where guidelines have recently changed and may come about to be changed in the future. So who determines these guidelines? So I mentioned that we did a bunch of studies that take a look at these things, and then medical organizations take all this information and sort of synthesize it into the guidelines that we know of. And that includes organizations like the American Cancer Society, the National Comprehensive Cancer Network, United States Preventative Service Task Force, and more. These tests are primarily ordered by primary care providers. Sometimes if you follow with a subspecialist like a gastroenterologist or an oncologist like myself, we will also talk about these tests and order them. But by and large, primary care providers should be talking about this with you at your annual physical based on your age, gender, and all sort of the factors that we previously discussed. Now, in general, what are the risks of screening? And there are specific risks to each type of screening, but kind of the basic ones are radiation exposure as well as over-testing/biopsying. Sometimes these screening tests pick up findings that end up being benign, but you need to get tests or biopsies to confirm that. Overall, though, when a recommendation is made from any of the guidelines above, it is felt that the benefits of the test outweigh the risks of it, and that's been weighed in those trials. And then lastly, well, how do we decide what gets screened for? And it's based on a lot of different things, and the main thing is we tend to look at what cancers are the most prevalent, and so we talked about breast, prostate, lung, these are the colorectal, these are the most common cancers, and so tests were developed to screen for that. We also like to take a look at what cancers cause the most death, so lung cancer, and that's how lung cancer screening came about. We also have to have an easy test modality that works and that isn't too invasive that screens for it. So there's various factors that go into this. And we're going to talk a little bit about specific different tests that we use to screen for specific kinds of cancers coming up. So the first topic we're going to cover is colorectal cancer screening. And so this is obviously screening your colon for any cancer or precancerous conditions. The lifetime risk of colon cancer is about 4% for the average man or woman. The goal of cancer screening for colon is to identify colon cancer before it becomes advanced, so at a localized stage where we can deal with it. And then you also want to identify and remove polyps because they may become cancer down the road. And then it can also be used to diagnose other non-malignant conditions such as like hemorrhoids, diverticulosis, or inflammatory bowel diseases, and et cetera. So some risk factors for colorectal cancer that everyone should be aware of is as you age, your risk of colon cancer goes up. Obesity and diabetes are correlated with a higher incidence of colon cancer. A diet high in red meat and processed meats is also increased risk for colon cancer, and actually particularly grilled or kind of charred meat is associated with higher incidences of colon cancer as well. And then tobacco use as well as alcohol use do contribute to your risk of colon cancer. So who should have colon cancer screening? And it's the same guidelines for both men and women, so gender doesn't really play a role in how we determine this. But the average risk person should start screening at the age of 45, and that should go up until the age of at least 75 years old. So this is a little bit of a change. I mentioned how guidelines changed previously, and it used to be that 50 was the age of starting. But at this time, it's 45, and there's some studies that are looking at whether or not we even need to push that earlier or not. But right now, between the ages of 45 to 75. And who qualifies as an average risk person? So all things sort of being equal, a patient who has no history of polyps, no history of inflammatory bowel disease, and no known genetic syndromes that predispose to colon cancer. An average risk person who has a family history also needs to be aware they might qualify for enhanced or more screening. And this is particularly possible for patients who have a first-degree relative with colon cancer. So that would be someone like a parent, a sibling, or a child who has colon cancer. And for those people, you would begin screening at the age of 40, so 5 years earlier, or 10 years prior to the early diagnosis. So if you have a father that had colon cancer diagnosed at the age of 48, you would begin screening at 38. If you had a sibling that had cancer at the age of 51, you would just begin at 40. So whichever one comes earliest is where you begin your screening. Second or third degree relatives, so that would be like your cousins or your aunts and uncles, you would just begin at the standard age of 45. So what are the options patients have for colon cancer? There's a few different options, and we're going to talk a little bit about the pros and cons so you can be aware of it. Colonoscopy is the most well-known one, and it is really honestly still the gold standard for colon cancer screening. You visually look in the colon for tumors or polyps, and you can remove them, you can biopsy them, and this gives the procedure a lot of diversity in what it can and can't do. The pros, like I mentioned, it is the most sensitive test available, and the cons are fairly obvious in that no one likes to do the prep. It's a little bit uncomfortable and it requires time. And the risks associated with the procedure. So you have anesthesia, although it's a fairly short amount of anesthesia, 20, 30 minutes usually. There's risks associated with biopsies such as bleeding or local complications. But again, all the studies that look at colonoscopy for colon cancer screening show that the risks are quite minimal compared to the benefits, which people who undergo regular screening colonoscopies are known to live longer than people who don't get regular screening colonoscopies overall. Some other options that you might have heard of are stool-based testing. So this is where they take the stool and they test it for either blood, which can be a sign of cancer or polyps, or they actually look for cancer DNA in the stool. And that was Cologuard is like a commercial you might have seen. That is a cancer DNA test. And the benefit of this is it's not invasive. You just have to submit a stool sample. You don't have to undergo a test, but it's not particularly sensitive. So it doesn't always pick up colon cancer. It can miss it more than a colonoscopy can. And what's really important, I think, is that you can't remove polyps. And over time, polyps can become colon cancer. And so that part of a colonoscopy is really important because not only is it looking for cancer, but it actually is preventing cancer. A flexible sigmoidoscopy is not very much used anymore. It's simply a colonoscopy, but they only look in the left part of your colon, so they miss an entire 2/3 of the colon. The benefit is that it's a little bit less invasive than a colonoscopy, but it just doesn't make, I think, sense to do a flexible sigmoidoscopy because you're missing an entire 2/3 of your colon. A CT colonography is used a lot of times with inflammatory bowel patients, and what that is a scan that takes a look at your colon for cancer and polyps. The pro is that it's not invasive and it's a quick scan, but the risk is that it's not as sensitive, and again, much like the stool-based testing that I talked about, you can't remove polyps, so you can't prevent that risk. So this is a kind of sciencey diagram, and I really don't want to go too much into the particular numbers of it. But on the left side, you can see that the higher the bar is, the more sensitive the test is for picking up different kinds of adenomas, polyps, or colon cancer. And then you can see the various tests at the bottom. So to the left, you can see colon cancer has the highest sensitivity in everything. So it is the best at detecting all types of findings. The FIT testing, which is next, is just another stool test, as well as the GFOBT is another stool test, which you can see towards the right. And these are, while they can pick up most things, they don't pick up as much as a colonoscopy does. And then we talked a little bit about the CTC, which is the CT scan for colonography. It is sensitive, but again, it can't treat polyps, and it's not as good as the colonoscopy. So overall, colonoscopy is still the standard of care, but it obviously is an invasive test. So if you, for some reason, cannot undergo a colonoscopy or for medical reasons, or you really, really don't want to, then I think the other options are reasonable to consider. So you're at least getting some screening, but colonoscopy still remains the gold standard of screening tests. And then the next question is, well, how often do you need to be screened for colorectal cancer? And at minimum, you should be getting a colonoscopy every 10 years. And it really depends, though, on what your finding is at your first colonoscopy. So if you have a lot of polyps, then you might need to increase the frequency depending on these results, because as I mentioned, polyps can become cancer down the road. That process usually takes about 5 to 10 years to happen, which is where the sort of recommendation for every 10-year colonoscopies comes from. But again, depending on what the gastroenterologist finds, you may need to get screened more frequently. If you're doing stool-based testing modalities, so that's the Cologuard or looking for DNA or blood in the stool, then you need to do that at least once a year. And then if any abnormality is found, you're going to need to do a colonoscopy afterward to follow up. And similarly, CT colonography and sigmoidoscopies, they should happen every 5 years, but if anything is abnormal, you're going to need to undergo a colonoscopy to investigate that further. So moving on from colon cancer, we're going to talk a little bit about breast cancer screening. So breast cancer lifetime risk for women is about 1 in 8, so 12 to 13% of women will get breast cancer, which is pretty significant. The goals of screening for breast cancer is to, again, identify it before it becomes advanced. And then you also want to identify pre-malignant conditions that put patients at higher risk of breast cancer as well, because you can sometimes either surgically deal with those or you can medically treat those as needed. So what are some risk factors for breast cancer? So similar to colon cancer, age, use of estrogen-containing compounds increases your risk of breast cancer. Postmenopausal women who are overweight have an increased risk of breast cancer. And then dense breast tissue, early menarche or having your period start when you were younger, late menopause also is an increased risk for breast cancer, and then nulliparity or not having any children can increase your risk. Older age at first childbirth and then significant alcohol use can all increase your risk for breast cancer. So a lot of different factors here. A lot of them are dependent on just the amount of hormone that your body is exposed to. So who should get breast cancer screening and how often should it be done? So for the average risk woman, there's a few different categories to consider. So between ages 40 and 45, you should consider screening and discuss it with your physician or with your primary care provider, because there's no set guidelines, but a lot of societies are recommending that at 40 it should start to be considered, which is very different than a few years ago where 50 used to really be the cutoff. It's lowered a little bit. For ages 45 and up, screening is recommended by some societies, not all, but definitely at age 50 to 74, screening is universally recommended for all women, and this is done annually or once a year. So we can talk about various breast cancer screening modalities. So the main one is mammogram, and it's very well known because it is a really good test. It's X-ray based imaging that sort of gives us a look at the breast tissue, kind of gives us the ductal architecture, and it can also look for things like calcifications that can suggest cancer. So that's kind of the pros. The cons are that if you have denser breasts, it's a little bit less useful. And so sometimes you end up needing to get more testing, especially if you have known dense breasts. Ultrasound is just an ultrasound of an entire breast or a localized area within the breast. It's a very non-invasive test. It's good for looking at specific areas of concern that might arise on a mammogram. And it's good for dense breast as well, but overall does give less detail than a mammogram would. And then lastly, breast MRI. So that's magnetic resonance imaging. It gives a really nice image of the breast, the lymph nodes, the tissue, and it's highly sensitive. But the cons are that it's an uncomfortable test and it can be long. So we don't use this for everyone. So really, mammogram is the mainstay, and then you can use ultrasound and breast MRI in addition as needed to help clarify any abnormalities or to further investigate in a patient who might have denser breasts. So I wanted to kind of highlight a couple specific populations here. So high-risk women. So this question comes up a lot, and a lot of women are probably contacted about this information and don't know really what it means. And so who are high-risk women? High-risk women are patients who are calculated to have a lifetime risk of breast cancer greater than 20%. So if you remember, 1 in 8 women are likely to get breast cancer, but this means if you have a risk of 1 in 5, you're high risk. And how it's calculated is based on various models called the Gale model or the Tyrer-Cuzick model, and they input a lot of information such as your age, your breast density, your family history, and when you started your period, when you ended your period, and all of that to get a number. And that number is your lifetime risk of cancer. And if it's greater than 20%, you're considered high risk. In addition to that, if you had a history of radiation to the chest between ages 10 and 30 years old, for example, if you had a history of lymphoma or other cancers that required that when you were young, you're at a high risk of developing breast cancer in that area. So if you are a high-risk woman, what should you do? And they should be screened at least annually with mammograms. But they should also have MRIs of their breast annually. And the way I like to do this is I usually will recommend that you get a mammogram now, and then in 6 months you get an MRI, and then you just alternate between the two studies. That way, every 6 months you're sort of getting some breast imaging staggered, but you're only getting a mammogram once a year, and you're only getting an MRI once a year as well. Similarly, high-risk women should also have consideration given to genetic testing, especially if they have multiple family members with cancers such as breast, pancreatic, or prostate cancer. And consideration should also be given if you have a very high lifetime risk of breast cancer to medications to help prevent that risk. So there's a few different things that these women should be aware of. And lastly, I want to talk to the men. So male breast cancer is not something that's talked about a lot, but it happens because men do have breast tissue. There's no screening recommendations for men because it's not very common. It's quite rare, but men can get breast cancer. And so I just want everyone in the audience who's a man to realize that if you feel something abnormal, you should bring it to the attention of your physician or provider because you might need a mammogram. So moving on from breast cancer screening is lung cancer screening. This is somewhat new and I think a very important advance that was made in the cancer screening realm because if you remember, lung cancer is the number one cause of cancer-related death in the country. The lifetime risk of lung cancer for non-smokers is about 1%, so it's fairly minimal, but it increases to 15 to 30% in people who do smoke. So the goal of lung cancer screening is to identify lung cancer in the smoker population before it becomes too advanced to deal with appropriately or safely. So risk factors for lung cancer: smoking cigarettes, which we obviously talked about. Smoking cigars and pipes also does contribute to your risk of lung cancer. Asbestos exposure, I know a lot of people think of mesothelioma because of the commercials, but asbestos exposure can also lead to increased risk of other types of lung cancer, and it's mostly through occupational hazards. It's not so much through incidental exposures, but like I said, mostly occupational hazards, and then radon exposure, which is something that you test your house for periodically. A question that I do sometimes get is about e-cigarettes and vaping and their risk for lung cancer, and it's just too early to know. We don't have those studies back. Certainly inhaling things into your lungs concerns me in that I don't know what those chemicals do when they react with your lungs, but we don't have the data yet to say that it does cause an increased risk of lung cancer or that it doesn't. So who should be screened for lung cancer? So the guidelines are the same regardless of gender. It really has to do with your age and your smoking history. So anyone who is between the ages of 50 and 80 with a 20-pack year history of smoking, who is either currently smoking or has quit within the last 15 years, should get screened. And when I say 20-pack year history of smoking, I mean someone who smoked 1 pack per day for 20 years or an equivalent. So that could be 2 packs per day for 10 years, so 2 times 10, or it could be 3 packs per day for 6 to 7 years. Those are the patients that should get screened. The exact guidelines vary depending on the society. So there are some variations in terms of the age, and this age group is recently expanded. Before it used to be a little bit of a narrower age group, but now it's recently expanded. But the exact guidelines depend on the society, and the above is the United States Preventative Service Task Force recommendation. And so what do we use to screen for lung cancer? And it's something called a low-dose CT chest. So it's a non-contrasted scan, so you don't need any IVs or you don't need any contrast given with it. That takes less than 25 seconds, so you go in the tube and you're out within 30 seconds, and uses less than 10% of the radiation of a standard CT scan. So it's very minimally toxic in terms of radiation, and I know that's a lot of people's concern when they go in for extra scans and extra tests. I just kind of wanted to give you a little picture here of the 2 different kinds of scans. So over on the left, you can see it's a little bit of a sharper image, and then that arrow is pointing towards a lung cancer. It's quite small, not easy to notice, but it's there. To the right, you can see this picture is a little bit grainier, but you can see there's a same size cancer pointed to with the arrow there, and it picks it up. So these CT scans save lives, and they are easy and quick, and they should get done for anyone who meets the criteria in terms of their smoking history. I think that was all I wanted to discuss. So prostate cancer screening is a little bit interesting in that it's a little bit controversial, and the guidelines are sort of all over the place with this. The lifetime risk of prostate cancer for men is about 13%, so about the same risk that women have for breast cancer, about 1 in 8. The goal of prostate cancer screening is to identify prostate cancer at an early stage where it can be dealt with through surgical means or with radiation. Risk factors for prostate cancer include age, family history, a diet that's high in animal fat and low in vegetables and fruits, smoking, testosterone replacement and supplementation, and then obesity also is a risk factor for prostate cancer. So I mentioned earlier that it's controversial. There's no clear consistency amongst the guidelines. It's an easy screening test to do. You just perform a blood test called the PSA, and it's usually repeated every 1 to 2 years based on results. It's something that people can begin discussing at around age 50. The benefits I sort of talked a little bit about earlier, in that you can maybe detect something that happens earlier when curative treatment might not be possible, or might be possible, sorry. But I mentioned how a lot of our strong screening guidelines have been proven through multiple trials where they showed a benefit in terms of survival and symptoms. There's been no study that's shown that PSA screening improves survival or symptoms from prostate cancer. And so this leads us to the risks. The risks start to get closer to the benefits. And we know with prostate cancer, the PSA being checked too frequently leads to a lot of biopsies, referrals that maybe didn't happen or didn't lead to a cancer diagnosis, because another important thing to know is that PSAs can rise just as you age naturally. They don't necessarily have to be correlated to cancer. So in conclusion with kind of this topic, there's a lot of guidelines and there's a lot of uncertainty, and it's really just a discussion that you should have with your provider about if this is right for you, if it makes sense or not. The last cancer that I wanted to highlight a little bit was cervical cancer screening. The lifetime risk of cervical cancer is about 1% or less in America, and it's more in developing countries, but this has really taken a sharp dive since HPV vaccine has come out. The goal of this is, like kind of all the other cancers, is to identify it at an early stage and identify pre-cervical cancer lesions that can be treated through local procedures and prevent it from becoming cancer down the road. So the risk factors for cervical cancer include high-risk sexual activity, immunosuppression. So if you've had like an organ transplant or a blood condition, you're at higher risk of this. Cigarette smoking, having a family history, and then most importantly nowadays is not having an HPV vaccine puts you at risk for developing cervical cancer. So cervical cancer screening is performed via the pap smear, which is really just where a provider takes a sample of the cells at the cervix just through a swab. It's not a biopsy or anything. And then the pathologist takes a look at that sampling under a microscope to look for abnormal cancer cells. The recommended age and frequency begins at 21, not 18, like a lot of people think. So at 21 through 29, you should get screened every 3 years. And then between the ages of 30 to 65, you want to get screened every 5 years if you're negative for HPV. Now, this is important because I think as women age, they sort of fall off and don't get as many cervical cancer screening tests. But really, it is something that you should be getting every 5 years at minimum up until the age of 65. So I just wanted to touch a little bit about some other cancers and screening tests that I get asked about frequently. So pancreatic cancer, if you remember, causes about 8% of cancer-related deaths in our country right now. So it's not a very common diagnosis, but it is a very deadly diagnosis. And endoscopic ultrasound, which is an EGD where they take a camera down into your stomach and look at your pancreas with the ultrasound, or an MRI can be used, but there is no consensus that this provides benefit in the regular population. So this is only used in high-risk patients who maybe have a genetic condition or some sort of other medical condition that leads them to have increased risk of prostate cancer. Then screening for other gynecologic cancers, so that would be like a uterine cancer or an ovarian cancer. Pelvic ultrasounds can be used in certain high-risk patients, but not used standard in the regular average patient population. And then I just sort of wanted to talk a little bit about skincare for 1 second. You know, it's important to be aware of your skin because any lesion that's growing or changing could represent a skin cancer and should be checked out and followed up, because skin cancer is very treatable at early stages and becomes more and more difficult to treat the more advanced it is. That is also why it is so important to use sunblock and to wear long sleeves out in the sun as much as possible to prevent sunburns, because the more sunburns and the more sun damage that you get on your skin, the more likely you are to develop a skin cancer. So just my little plug on that. So in conclusion, we talked about colorectal cancer, and colonoscopies are the standard of care for this and should be performed at least every 10 years after the age of 45. Breast cancer is best screened for with a mammogram that should be performed yearly after 50 and probably earlier. And then ultrasound and MRI can be used as an adjunct to this. Next, lung cancer. This one is really important for anyone who's smoking. Low-dose CT tests need to be done yearly if you have a 20-pack year history. So 1 pack per day for 20 years or the equivalent. Prostate cancer, that one was controversial. It's a blood test that you would do, and you should just really talk to your primary care provider about whether there's a benefit for your situation. And then lastly, cervical cancer screening is done with a pap smear that should occur every 5 years, and you need to get them done up until the age of 65 years old. So these guidelines are all available on various websites. So the United States Preventative Service Task Force, National Comprehensive Cancer Network, and American Cancer Society are just a few that have kind of free access for patients to look this information up. With that, I just wanted to say thank you and see if anybody had questions.
All right. Remember to put it into the chat box if you do have a question. Just give him a minute in case somebody does. Well, looks like we don't have any questions. You must have answered them all. Lots of wonderful information, and we thank you for preparing your time, preparing it and presenting the program. So thank you very much. I would like to remind everyone of our upcoming Primetime Alive programs. In case you didn't see the email yesterday that Vicki sent out, tomorrow's program on the 14th is being postponed. She will send out more information later about when that will happen, probably in June. The fall prevention program is on Tuesday, May 3rd at 2 p.m. And on May 18th is Pinterest. What is the excitement and fun all about? And then you can sign up for a fall and balance screening, and that is here at Mary Greeley. And an appointment is required, and you can call our office at 515-239-2423 to get your 15-minute appointment for that. And that's here from 9 a.m. to noon. It's on an Atrium A, is located on the second floor across from the entrance to the cafeteria. So we thank you again for joining us today. Have a great rest of your day.